Good morning, and thank you for the opportunity to introduce our speaker today in honor of Hispanic Heritage Month. I have the pleasure of introducing Dr. Victoria Parente. She is an assistant professor of pediatrics and is attending in the Division of Hospital Medicine at Duke University. She completed her undergraduate degree right down the street at Stanford, and then got her medical degree and her MPH at Stony Brook in New York, and then completed her pediatric residency and chief residency at Duke University Medical Center. Her research, which she'll be talking more about today, has been supported by the NIH and several other grants, including K-12 through Duke, and then a K-23 through the NIMHD. And her research has been published in many top-tier pediatrics journals and has really been recognized multiple times as very impactful, including twice having one of the top 4 research abstracts that was presented at our annual Pediatric Hospital Medicine Conference. She's also presented at the APA presidential plenary sessions. I've gotten to know her through many realms, but one of the things that I've worked with her closely is I sit on the Hospital Pediatrics, which is our journal's flagship journal, and I'm an associate editor there, and she serves on our editorial board, where I lean on her very heavily for her quality reviews and expertise in health equity, language access, and on the intersection of equity and QI. So please welcome Dr. Parente, whose talk is entitled Cultivating Trauma-Informed Communication Practices.
Thank you, Dr. Russell, for that introduction. I'm really honored to be here today and to share with you some of the work I've been doing to try to improve communication with patients and families in the hospital, really using an equity-focused and trauma-informed lens. So as Dr. Russell mentioned, I'm a pediatric hospitalist. So much of the work that I'm going to talk about takes place in the inpatient setting. However, I really feel like many of the communication principles really apply across contexts and settings. I broke this talk up into 3 main sections. First is talking about where inequities exist, with a focus on differences in communication quality by language, race, and ethnicity. This is an important first step and actually where I started my own research journey, because I want to better understand what are the areas or domains where inequities exist that we might be able to improve communication quality. Then thinking about how interactions really, we think about healthcare interactions just as this one-time event, but really they're a point in people's lives, and thinking about how those past experiences and journeys might affect the way that they talk, act, and behave in that current encounter. And recognizing that healthcare itself can sometimes be traumatic. And so how can we use best practices in trauma-informed care to really ensure the highest quality communication with our patients and families? And then lastly, talking about some strategies that I've learned along this journey that I use in my own clinical practice, as well as in my research. I've designed an intervention to try to make communication more inclusive, equitable, and trauma-informed. So before going into those objectives, I just wanted to pause and say that communication is really critical. It's a foundational piece of high-quality medicine and has important short and long-term benefits. Sometimes it's sort of seen as a soft skill, but it's really essential to high-quality care. And so there's been several studies that have shown an association between high quality communication and improved patient satisfaction, reduced anxiety. Specific to the hospital setting, we know that when patients and families are more engaged in their child's care, it leads to less medical errors and safer practice. It also leads to improved understanding and medication adherence. And lastly, reduced ED visits and readmissions. So now going into that first topic, where do inequities in healthcare communication quality exist? And I also broke this up into 2 sections. First, thinking about inequities by language, and then thinking about inequities by race and ethnicity. I'm going to use the term language other than English, or LOE, throughout this talk to refer to patients and families that use a language other than English for healthcare. And we know that when admitted to the hospital, patients and families that use a language other than English have worse hospital experience and outcomes. So there's a wealth of data that shows this, including things like lower comprehension, adherence, and satisfaction, up to $20,000 in higher costs and longer hospital stays, an increased odds of readmission to the hospital once discharged, a 2.1 times higher adjusted odds of having an adverse event, and even increased mortality. We also know that professional interpretation can help to mitigate some of these inequities, but is overall underutilized. So in a national survey in 2023 of pediatric hospitalists, they asked them about access to interpreter services. And what they found was that increasingly services are available, with over 90% of institutions reporting that they have access to video, phone, or in-person interpreter. However, despite this increase in access, interpreters are underutilized and might vary by task. So when they asked them, how often do you use an interpreter for different clinical contexts, majority said that they used an interpreter when getting a history or admitting someone to the hospital. But only 40% reported that they always used an interpreter for family-centered rounds. And in an observational study in the pediatric emergency department, where they filmed encounters, they actually found that only about 10% of the time was an interpreter used for certain things like doing a procedure or administering a medicine. And in multiple institutions across the country, different institutions are measuring how often are interpreters being used as part of quality improvement to try to increase the use of interpreter services. And a lot of times when they look at this data at baseline, interpreters are used about 1 to 2 times per day, which on the surface you might say like, oh, that sounds pretty good, like an interpreter is being used every day. But when you think about the number of times that an individual goes into that child's hospital room, whether to administer a feed, to give a medicine, to clean the room even, all of those are opportunities that an English-speaking family would have to ask a question or to speak up about something that a family that uses a language other than English does not have. We also know that interpreter use is associated with better outcomes. So this was a retrospective study of rapid response events for children in the hospital. And they found that when an interpreter was used less than once per day, that child had an increased risk of being transferred to the ICU and having a rapid response called. My colleague at Duke, Michelle White, wrote a commentary that I thought really captured this well. She said, each time a member of the medical team goes into the room of a patient who speaks a language other than English without an interpreter, it effectively silences that family. We also know that even when interpreters are used, there's a lot of variability in how teams use an interpreter. So there's some variability in modality, whether it's an in-person, video, or phone interpretation. By and large, families prefer in-person interpretation over those other modalities. However, when that's unavailable, video interpretation has been shown to lead to better comprehension than phone interpretation. Now, in general, bilingual providers are really valued and cherished by patients and families, but specific to family-centered rounds, qualitative studies have shown mixed reviews from families about bilingual providers. Some families reporting that when one member of the medical team spoke their language, there tended to be more summarizing of information than when they had a dedicated interpreter in the room who went line for line interpretation. And it's really hard for a bilingual provider to fulfill both roles of interpreter and provider. So for this specific context, it's really great having an in-person interpreter if that's available. And that kind of leads into the next session of variability. There's a lot of differences in summarizing. Some teams will go line for line interpretation, and others will kind of have a whole conversation between themselves and then just summarize at the end. There's also studies have shown that there's more likely to be these kind of side conversations, people like talking to each other rather than directly to the family when they use a language other than English. And lastly, in observational studies in multiple contexts, including PICU family-centered rounds, as well as outpatient settings, in general, when a family uses a language other than English, doctors tend to dominate the conversation more, and patients overall speak less. So wanting to learn more about what was happening at my own institution with the goal of improving and enhancing care, I did an observational study of family-centered rounds. And we did this on hospital day 1, thinking that on hospital day 1, there would be the greatest medical decision-making that would occur. We audio recorded family-centered rounds, and then a priori decided what skills we were looking for in clinicians. And so this included best practices in patient-family communication, things like asking an open-ended question or active listening skills. We had medical students who were code the encounters, listening to the audio recordings, and count these number of behaviors. And then we had patients afterwards and their caregivers just referring to the parent, family member, or guardian in the room, complete a survey about their satisfaction, trust in their child's doctors, and how they feel like the communication quality was. And then we looked at differences by language, race, and ethnicity. So these are some of the objective communication measures that we looked at. We looked at team behaviors, how often they asked an open-ended question, things like, how was your child's night? How often they demonstrated active listening by reflecting back what the patient and family said, how often they elicited questions or concerns from the patient or family, or gave an empathic statement or response when a family expressed an emotion. We also used a count of how many times the parents or caregivers participated in the encounter. This didn't include things like when you asked them a question and they responded back, but how many times they on their own asked a question or gave an assertive response, things like saying their opinion or preference, how many times they expressed a worry or emotion. And then the medical students listening to these encounters also gave a global rating of their general gestalt in several domains, including flow, how well the conversation went back and forth, how much respect and value for the caregiver there seemed to be, partnership, how well the caregiver's concerns were addressed, whether or not it seemed like the team gave that caregiver full attention, and how much warmth there was. And so overall, we had 341 parents and caregivers that were eligible for this study. Some of them didn't have a caregiver at the bedside, and so were not enrolled. 252 did have a caregiver present. Majority of those completed a survey, only 39 declined. And then a subset of those had an accompanying audio recording. Because we really intentionally wanted to look at differences by race and ethnicity and language, we selected a diverse group and had 20 Black, 19 Hispanic, Latino, 20 white, and 2 more than one race caregivers. And 10 Spanish-speaking families were in this study. And objectively, what we found was that in those encounters where families used a language other than English compared to white English-speaking families, first, all had a professional in-person interpreter present, which I think was awesome. I will say that this study was done right before COVID, and I feel like since COVID, we've had a little bit of a shift of people using more video interpretation and that becoming more available. So I don't know if I did this study today, if that would still be the case. But we also found that those families were asked 2 times fewer open-ended questions, so less of those inquiries into the parent and family experience and how they felt like their child was doing. And that there was a lot of variability in how much time was spent in Spanish, so we counted the minutes and seconds in each language, and sometimes as little as 10%. So majority, 90% of the conversation happening between providers, or in the case where there was a bilingual teenager with that teenager with very little being interpreted for the family. And that they overall were treated with less respect, partnership, and attention. Kind of mirroring this, the caregivers with LOE also reported similar things. They felt like they had less comfort to participate on family-centered rounds and greater fear asking questions. They said they didn't feel like their concerns were fully elicited or that they were always treated with respect. And that overall, they participated less than white English-speaking families, about 3.3 times per family-centered rounds encounter compared to 8.3 times for white English-speaking families. And then only about 1 in 10 had complete trust in their child's doctors. And this is also mirrored in a multi-center study. So Shanika, one of the Pediatric Hospital Medicine Fellows, just recently published this paper here at Stanford in Pediatrics, looking at a 21-site multi-center study. And they did over 3,000 observations of family-centered rounds and looking by differences in language and that structured communication. I want to say that this study is interesting in that this was part of an intervention to improve patient and family engagement on family-centered rounds. So these are doctors who are already being coached in best practices to engage patients and families. And these are some of the differences that they observed within this study. Families that used a language other than English were less likely to have their diagnosis or differential explained, be included by the team, have the nurse engaged in rounds, which is a really critical feature so that everybody on the healthcare team understands the plan and that the nurse has an opportunity to advocate for the patient and family. And that families that used a language other than English or Spanish, so some of those languages of lesser diffusion, were less likely to share concerns. Another way that interpretation can impact the quality of communication is through interpreter alterations. So we know that going from one language to another is not a word-for-word interpretation. And so there can be these common differences that occur as you go from one language to another. One is an omission. So something gets left out of the interpretation, a substitution, something gets changed, or an addition, something gets added. And that these can have positive, neutral, or negative impacts on communication quality. So an example of positive is that the team says, okay, the child's going to be MPO at midnight. And the interpreter says, okay, your child can't have anything to eat or drink after midnight. So sometimes they're making these positive substitutions to clarify the context of what's happening. Sometimes they can be neutral and have no impact. or sometimes they could be negative where important pieces are left out. And so as part of designing an intervention to improve communication quality with families that use languages other than English, we wanted to understand how do medical team behaviors actually affect the overall interpretation quality that's happening. And so we did a secondary analysis of that observational study where we looked at each interpretation segment. So that was when one person was talking and then had pause, and then the interpreter had time to interpret that piece. And what we found was that interpretation alterations are very common. So 72% had at least one alteration in interpretation, with omissions being the most common, happening in 46% of segments, followed by substitutions and rarely additions. And then the graph on the right, I want to point you to is that it was largely influenced by how many sentences the medical team said. So when the team said one sentence, for example, if we look at omissions, about 35% of the time, something was left out in that interpreter alteration. When the team said two sentences, it went up to 52%. When they said three or more sentences, about 80% of the time, there was something being omitted in that interpretation. We also looked at whether or not we thought it might have an impact on the communication quality. And so was there a loss of biomedical information? You could see that same stairwise increase, that as teams said more than three sentences, there was almost a 0.5% chance that there was a loss of important biomedical information. But not just biomedical information was lost. We also saw that as teams said more than three sentences, there was a loss of partnership and social support. So the team might say something like, we're so happy that you're here, or it's really hard to be in the hospital. So the plan for today is that we're going to continue on the fluids, continue the Zofran, and then what would happen is that that beginning piece where there was some social support would get left out in the interpretation. So really pausing after these partnership building statements, after social support, to make sure that that's valued and seen as something important to interpret rather than just the biomedical talk. We also saw that when there was a bilingual child, there was more likely to be loss of information that occurred. So the team would just talk directly to the child. Sometimes children as young as 11 or 12 were really being responsible for their medical care in the hospital, and very little was being interpreted for their families. I think this is a really important, this was from the AAP Council of Immigrant Child and Family Health newsletter in the fall of 2023. By Mildred Taveras. And I just wanted to point out, this was her experience as a bilingual child that I think really does more value than any of the numbers that I just presented. She said, I remember going to the pediatrician with my parents and having to be the one responsible for interpreting for them, which was a lot of pressure to put on a child. I did not convey every concern or point the doctor made to my parents because I was ashamed. I didn't want to worry them and because I didn't want to get in trouble. This misinformation reflected on my health, especially my year-long struggles with obesity. I believe that had my parents been informed as to what was really happening and what the recommendations and concerns of my doctors were to improve my health, they would have done it and I would have benefited greatly. Struggling with obesity as a child is something that I most definitely did not have to go through, but my parents probably understood 50% or less of what the doctor said and recommended. The rest was on me. The rest was a big responsibility for me, a child. So summarizing where some of the inequities exist for LOE families, interpreter use is essential for high quality care. But even when an interpreter is present, there's a lot of variability in the communication practice that occurs. And that there's these inequities, especially in respect, partnership, and attention that can occur for families that use a language other than English. And that probably results in less comfort asking questions or fear bringing up their concerns, lower trust, and less participation. And also the way that we talk through interpreter-supported conversations really has an impact on the communication quality as far as the quality of interpretation that occurs, leading to both greater losses of biomedical and psychosocial communication, especially when we continue to talk without pause for interpretation. So now shifting gears to talk a little bit about racial and ethnic inequities in communication quality. So I want to acknowledge that this is built on a wealth of research in the adult and pediatric settings, and that even in 2001, when the Institute of Medicine released its Sentinel report, Unequal Treatment, Lisa Cooper and Deborah Roeder had a whole chapter on patient-provider communication in that report. So these are well-known, well-established across multiple settings. In general, in observations and surveys, Black and Latino patients have been shown to experience worse communication quality with clinicians, including less patient-centered language, engagement in decision-making, positive affect, respect, more hurried encounters, and greater conflict and miscommunication. I want to acknowledge that a lot of my work really focuses on these populations, in part because of the community of Durham where I work and serve, but there's also a growing research that shows this lower communication quality as well for Asian and Asian American families, including in discrimination and disrespect. So as I go through these studies, which really focus mostly on the above populations, I don't mean to be excluding other populations that also experience discrimination and worse healthcare communication quality. So why do these communication differences exist? Well, there is some evidence that it might be related to clinician implicit bias. So this was a really sentinel report by Lisa Cooper in the American Journal of Public Health in 2012, where before healthcare visits, she had clinicians take an implicit association test. Many of you probably are familiar with an implicit association test, but basically what it does is it looks at how quickly your brain associates positive and negative words with pictures of individuals. And in the race association test, which is the one she had them take, it varies people by skin color. And then, so you look at how quickly your brain associates these different words with different pictures of people. She also had compliant patient words, which were things like willing and reliable versus reluctant and apathetic. And then she audio recorded clinical encounters of these same clinicians with 269 patients after they had taken that test. And what she found was that among Black patients, general race bias was associated with the doctors talking more or greater verbal dominance, lower patient positive affect, and those patients rated those encounters as having lower interpersonal care. And when doctors had this greater medical compliance stereotyping or a stronger association between race and compliance in their brain, those doctors tended to talk slower, have less patient-centered communication, and again, those patients reported those encounters as having less positive interpersonal care. So one mechanism through which these communication inequities probably occur is through implicit bias. Again, we then wanted to look at what was happening in our own institution. So in the same study, we also looked at differences by race and ethnicity. And what we found was that Black and English-speaking Latino caregivers reported greater fear asking questions and that they had less time to ask questions. When the coders listened to those encounters, they didn't actually notice any differences in the specific skills we were looking at, like open-ended questions or reflection, but they coded those as having less respect and partnership. Objectively, we found that parents and caregivers participated less, and only about 1 in 3 had complete trust in their child's doctors. I think one of the most striking things from this study for me was just the difference in participatory behaviors. So family-centered rounds, really the ideal is that patients and families are engaged and sharing in medical decision-making. That's why we do family-centered rounds. But clearly that same equitable care wasn't happening across populations. And so what we found was that on average, white caregivers participated 8.3 times on rounds versus English-speaking Latinx caregivers 5.8, Black caregivers 5.1, and Spanish-speaking Latinx caregivers only 3.3 times on average in family-centered rounds. And so I really wanted to dig into this. What was driving these differences in caregiver participation? So I went to the literature looking, what do we know about what influences patient and family participation? And really the biggest driver is team communication. And so it can be these reoccurring cycles where when teams give families more information, they share more about the differential diagnosis and what they're thinking, caregivers then ask more questions. When caregivers ask more questions, the team gives them more information. And so it can lead to these reinforcing cycles where clinicians provide more information when patients are more active, and patients are more active when their clinicians give more partnership building statements and more information. I also thought about the difference between equality and equity. So one thing I noticed is that often teams were going into the room and starting the same way with every patient or family. How was your child's night? That's usually the standard. But that what was happening was that we weren't getting equitable responses. Some people would just say, fine, no concerns. Other people would say, give a lot of information. Well, they had a rough night at 3 a.m. This happened. And so I started thinking about what factors outside of this room were influencing whether caregivers felt like they could show up and participate, that they felt safe to bring up their concerns immediately. And thinking about structures outside of the healthcare system that might be influencing this. So, one of those of which I've explored is how do past experiences of discrimination influence the way that patients then talk in future healthcare encounters? So, in this study, prior to a primary care visit, this is in adult populations, they had patients surveyed about their past experiences of racism and classism prior to their clinic visit. What they found, and then they audio recorded that future clinic visit. And what they found was that Black patients who reported a history of discrimination prior to that visit, these were often things like not being listened to or feeling like they'd been treated with less respect previously in healthcare settings, demonstrated less positive affect in that future encounter. And then in turn, their clinicians were also coded as having less positive affect. So again, patients who are perhaps rightfully wary of healthcare encounters based on their past experiences might show up with more vigilance or looking for cues of threat. But the way that that's perceived by clinicians is that perhaps this patient doesn't want to engage with me. And so if clinicians are not aware of how systems and structures of racism and discrimination can then trickle into their own clinical room, it might actually lead to worsening of these stigma and stereotype of feeling like, oh, well, this patient, they were really disengaged. But really what was happening was that they needed more invitation to feel safe and welcome in that environment by their clinician. So I also looked at this in family-centered rounds. This is some preliminary data. This was a secondary analysis of family-centered rounds recordings. We had 32 Black and 25 Latino caregivers. And in addition to the recordings, we had them fill out a survey about their past experiences of discrimination. We asked about discrimination in all sorts of settings, education, with the police, with banking, with housing, because we had this theory that perhaps if in multiple institutions and settings you'd experience discrimination, even if it wasn't in healthcare itself, that it might influence the way that you show up in a healthcare setting. And what we found was we classified caregivers into these three groups: those who had never reported any past discrimination in any of those settings, those who reported discrimination outside of healthcare but not in healthcare itself, and those who had reported discrimination in healthcare. We then, in those same recordings, deductively coded those caregiver participatory behaviors, the same ones of asking a question, making an assertive comment, or expressing an emotion. And we also inductively looked at what the caregivers were saying. What were they contributing to family-centered rounds? Were they seeking more medical information? Were they sharing medical information? Were they sharing non-medical information? Were they advocating for their child? And we separated that into 8 different categories. And then we looked at the relationship between caregiver participation on rounds and their past experiences of discrimination. And I was actually surprised by what we found. I thought that when parents had experienced discrimination inside of healthcare, that they might participate less on rounds. And I was sort of basing that on some of the preliminary data I've shared with you. But we actually found the opposite. So when caregivers had past healthcare discrimination, we actually found that they participated more. So the median times of participation when someone had experienced healthcare discrimination was 10.5, versus outside of healthcare or never discrimination was much lower, about 3.0 and 4.0. Qualitatively, when we looked at what were they saying, what were they contributing, there was a lot greater advocacy. Things like, I would love to wait till she perks up a bit before going home. Logistical questions. Okay, so who am I going to go through for that? Is it their primary care, or who's going to take care of that? And also seeking information, like what happened to the blood cultures? What was the result of the blood cultures? And so our theory is that this is driven by this sense of increased vigilance to assure that their child is going to receive the highest quality care and treatment, that they feel like they need to ensure and advocate for their child, understand who's going to be accountable for different tasks in the hospital and the logistics of how it's going to happen so things don't get lost, and making sure that things are not getting lost. So really double checking some medical information. And again, despite kind of that they participated less, these same caregivers actually reported lower partnerships. So they rated their doctors' interpersonal communication as lower. And so I think it's this same negative cycle that can occur where families have this increased hypervigilance, which is actually sometimes construed as maybe being difficult or questioning the expertise or the authority of doctors, when really it's based on these past experiences, feeling this need to assure that things are not going to get lost or missed. So kind of a summary of where some of the racial, ethnic communication inequities exist and that we found. The robust documentation of inequities across settings. There's an association between bias and poor communication quality. On family-centered rounds, we found differences in respect and partnership. And past discrimination can affect the way that patients and caregivers participate and behave in clinical encounters. So with that in mind, we work towards developing a trauma-informed intervention with an equity-focused lens. So why trauma-informed? I haven't mentioned that at all to date. I felt like a lot of the principles of trauma-informed care really aligned with what I was trying to do. It recognizes that patients' lived experiences and past experiences outside of that clinical encounter can affect the way that they talk, act, and behave. It recognizes that not everybody is going to come into a healthcare setting feeling trusting and comfortable with their providers, and that actions need to be taken to make people feel included and safe. And it really values diversity of background, culture, and experience. So some of the trauma-informed principles, there's 6, include safety, promoting physical and emotional safety, empowering people and respecting their choices, collaborating, shared decision-making, being transparent and trustworthy, letting people know what to expect and following through, embracing diversity of voices, and valuing lived experience. So sort of in the standard approach, we assume patients trust us when we ask, how's your child's night, that they're going to tell us everything. But in a trauma-informed approach, we know that trust has to be developed over time. In a standard approach, we assume patients feel safe. But in a trauma-informed approach, we have to take steps to ensure safety. In a standard approach, we interpret behaviors through our own lens and viewpoint. Well, they're not participating a lot, that means they're disengaged. But really trying to understand patient and family perspective and being curious when people are not behaving the way that you might expect or saying things that you don't understand. And also being aware of how power imbalances, racism, and history actually interact with your current clinical environment. And so as part of this intervention development, based on those studies we showed before, we had kind of a prototype, or where were the areas we wanted to focus. Clearly, respect and partnership kept coming up. We wanted to focus on how do you work with an interpreter, recognizing that there are language-specific inequities that we were seeing, and based on the literature. But we also wanted to hear from parents about the intervention that we were developing. What are some areas that we're missing, and how could we grow? So we had this prototype, and then we interviewed 14 caregivers and 7 clinicians, and kind of looked at their answers. One of the things we did in these interviews is we really delved deeper into participation. What influences parent participation? And here are some quotes from parents. One of the things they talked about was openness and respect. So in a positive, when they felt like their opinion was valued, they would speak up more. But if they thought that the doctors just thought, if you think I don't know anything, or if you're just looking at me as somebody who, again, they just Google everything or just go by whatever, how can you respect me as an equal on a team if you think I don't know anything? I should mention that these were all Black and Latino caregivers too that we interviewed. We also, one thing that came up is I haven't talked a lot about nonverbal body language, but this was probably the biggest driver, whether or not people felt comfortable participating. Whether they kind of took the time to sit down and what their body language was saying, but really more on the negative. If they felt like people were sitting there with their arms crossed or picking up on certain vibes of people in the room, like, why are you asking that question? This was the biggest driver where people were like, I'm not going to participate, when they felt these negative vibes or energy from people in the room. There were also these structural factors. Like, I thought also, again, my own biases, I was like, well, I think everybody's not going to like family center rounds because there's so many people in the room. So as an introvert, I feel overwhelmed when there's like a lot of people around me. So I'm like, that's probably what's going on. But actually, a lot of people enjoyed family centered rounds, having multiple voices and watching that transparency in action of seeing that there were multiple people who were saying the same thing, you know, the intern, the senior resident, and then the attending's like, yes, I agree. So some people really valued family-centered rounds in that way. But other times, clinicians talked about how sometimes on family-centered rounds, they would see that a patient or family was kind of disengaged or not really participating, but it was quicker to just keep going through rounds rather than taking the time to learn why aren't they participating? Because there's all these competing demands, right? You have to try to finish rounds, get residents to noon conference or whatever their learning activities are. So there's this dichotomy between really good patient-centered communication and also the time that it needs to overcome some of these structural barriers. And then also race and racism did come up. Some of the caregivers talked about when they had racially concordant providers, how that just made them feel more comfortable to participate, like they were being understood. There were also people who kind of talked about how they hear from others that doctors won't listen to you. And that influence, they're like, well, why am I going to talk when I know the doctors won't listen to me? And I wanted to just touch on, for me, I wasn't really thinking a lot about nonverbal communication. And my mentor was like, well, sure, 93% of communication is nonverbal. I'm like, where does that stat come from? So this was actually a really old study from the 1960s with college undergrads, so probably not the most diverse representative population. But they asked them, they did this series of vignettes where they had people make decisions based on when a speaker's words said one thing, but the nonverbal behavior said something else. And actually only 7% of the decisions were based on the verbal message, 38% from tone of voice, and 55% from the nonverbal body language. So it's not always what you say, but how you say it. So I'm not sure exactly how you teach that to individuals, but really being aware of how bias might impact or show up in your body. It's an unconscious thing that you may not even be aware of. And so recognizing how that might show up. And in video encounters of standardized patients, they've actually shown that there's a greater disparity in the nonverbal than the verbal communication that happens. So really just thinking about nonverbal communication as well as all these verbal skills that I've been talking about. Okay, this is a really busy slide, but this was the intervention that we developed. We developed a mnemonic train. The T stood for trauma informed, and it included things like rapport building talk. So really building connection and relationship building, making someone know that you see them as an individual. You're recognizing their humanity, you're learning more about them. And this, promotes safety. Asking for permission. So even things like respecting boundaries, I can't tell you the number of times I've observed a lot of family-centered rounds, people just reach over and mute the television, or they just examine the child without asking first. But really sharing power, asking permission, do you mind if we mute the television? It just gives people that agency and power and respect, and also lets them know what to expect. Okay, I'm gonna examine your child now. Respect, avoiding interruption. This was family focus groups on the adult side that really talked about how they hate being interrupted by doctors. And there's also studies that show doctors interrupt patients like every 11 seconds or something. So avoiding interruption really shows respect and value for the patient and family input, and that you actually want to collaborate and hear what they have to say. This nonverbal communication, we talked about open body language and how that promotes safety and trustworthiness. Affirming people, recognizing their strengths. Again, this just shows that you're empowering them. Like when they ask a question, one easy skill sometimes is to say, like, that's a really good question. That makes people feel more comfortable to ask more questions when you say that. Or you did the right thing bringing them into the hospital. You're the expert on your child. Really, these kind of things really empower patients and families to participate more. Again, providing emotional support as well, validating their experience. The flow, really slowing down and communicating in a non-rushed way, creating space for people to jump in and participate and collaborate, and being aware of how much you're talking and how much space you're taking up. And then lastly, partnership building statements, things like asking the caregiver their opinion and preference to really collaborate and empower individuals. So we pilot tested this intervention at my institution with a waitlist control trial, where some people got the intervention immediately and some people got it 6 months later. The reason we did this design was that we wanted to make sure that there weren't other things happening at one time if you just do a pre and post that might be influencing communication that occurs. The clinicians got coached on all of these skills with a didactic plus observed observation. So we would go and observe family-centered rounds and then be like, yeah, you did a really great job asking for permission. There was some opportunity for partnership around whether or not to stop the IV fluids. You could have, it might be a nice opportunity to just ask the family how they feel about it. And then we also, because this was in an academic medical center, provided teaching resources. So these were all attending hospitalists who participated, and we gave them a video that they could watch with their residents and had them pick one skill a day, or each individual pick a skill that they wanted to focus on and brainstorm with them different ways to incorporate this into their teaching on family-centered rounds. Overall, there were 8 hospitalists and then 46 caregivers who were blinded to whether their hospitalist had got the intervention or not. We audio recorded rounds and had them survey afterwards. And we measured the feasibility, acceptability, and preliminary efficacy of the intervention. These were some of our efficacy outcomes. So we looked at whether they were doing the train-specific skills and some of the global codes. And then also on the caregiver reported survey, we asked about satisfaction, trust, and certain elements of communication quality, like whether it was hurried, their concerns were elicited, there was shared decision-making, respect, and discrimination. These are the demographics of the hospitalists and the caregivers. They were all Black and Latine. 70% had a high school or less education, and 9 of those were Spanish speaking. And then the children themselves, majority were less than 5 years old, admitted for acute respiratory illness, 65% previously healthy. We purposely excluded children with medical complexity from this study, just recognizing that the communication is probably different on family-centered rounds for those children. And then 54% had had a prior hospitalization. What we showed was that doctors really thought highly, high feasibility and acceptability. We did a survey and we used a validated measure, the FIM and AAM, and no clinicians reported with a score of less than 4, with 4 or 5 being agree or strongly agree for those measures. So highly feasible and acceptable. We also did interviews with the clinicians after they participated, and overall they liked it, which I guess is good. But I thought more interesting is that a number of people talked about how it helped them to slow down and be more intentional about communication, how it's not something they usually teach or talk about on family-centered rounds, but that they really appreciated like focusing on that in their teaching. And it provided this structure to teach learners, and they really enjoyed like having specific, concrete, tangible resources that they could give to individuals. And what we found is that I didn't provide the numbers here or tables, but generally when we did the intervention, it increased clinician behaviors in things like affirmations, partnership building statements, respect, and then fewer interruptions. So those were all statistically significant between the control and the intervention arm. And that caregivers then, perhaps because of these changes in clinician behavior, reported greater trust in their doctors, greater shared decision-making, and feeling like their concerns were fully elicited. So in this pilot study, we showed that these kind of skills and this type of approach is feasible and acceptable and improve parent-reported outcomes. It was unique in that a lot of communication interventions focus on these kind of generic skills like open-ended questions, but we really focused only on areas where we found racial inequities to exist already. We incorporated these trauma-informed principles throughout, talking about in the video, we talked that the residents would watch about how lived experience might show up in the hospital room. Many communication interventions just exclude families that use languages other than English, but we included them. And a lot of communication coaching is like one-on-one in the outpatient setting, but instead we had a team communication. How do you teach learners how to incorporate these skills into their clinical practice? And one thing was that the attending hospitals are then modeling receptivity to feedback, and really that they value equity and that they value communication to their learners. And so I think that's also really important. A couple areas to note. One is that I really haven't talked a lot about language and racial concordance, which is really important, but it's hard on family-centered rounds in just that, there's so many different providers in the room. We really struggled with measuring concordance. Doesn't matter if there's a medical student who looks like you, or only the attending, or if there's more, like 50%, so what is concordance on family-centered rounds? I think is really challenging, but it's something important to think about. We, again, only included 3 racial groups, but recognizing that race is very fluid, and that especially in pediatrics, you may have the caregiver race might be different than the child's race or how they identify. And so really, in some ways, this is very simplified, but it's more complex than that. And that there's a lot of intersectionality and heterogeneity between different people's experiences. So kind of in conclusion, communication that focuses on respect, connection, and partnership can improve caregiver experience and trust. These skills can be taught and modeled in the clinical learning environment. But one area where I'd like to do more work through larger studies, so a lot of my studies have been very small, but through maybe a multi-center study, is what is really the impact of improving communication on long-term pediatric health recovery from illness, recognizing that hospitalization is just one point in that child's health and wellness, and that how we treat children in the hospital may actually have long-term impacts for whether they adhere to medications in the future or how they show up to future healthcare providers, right? We talked about how experiences of discrimination might influence future encounters. So what are the long-term impacts of doing interventions that improve communication quality? I think Dr. Russell mentioned that I'm currently just wanted to recognize that I'm supported by a K-23 award through NAMHD and saying thank you to all the people on my research and mentorship team. And then lastly, I know I was invited here for recognition of Hispanic Latino Month, Heritage Month, and I just want to say thank you to my family who modeled courageousness and resilience as immigrants to the United States, particularly my mom, who always valued human connection, calor humano, and the stories of others. So she always wanted to know people's story and listen to them. And I think that that really helped to inspire my research interests and career.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.